My name is Caitlin Walker. I'm a respiratory therapist with Evanta, and today we will be discussing weaning approaches. The goals for this presentation is to discuss ventilator liberation, weaning best practices, tracheostomy liberation, weaning best practices, weaning assessment tools, monitoring safety measures, post-liberation care, and monitoring. First topic we will discuss is ventilator liberation and weaning best practices. Understand the underlying cause of the initiation of mechanical ventilation. Identify the root cause of the event requiring the initiation of mechanical ventilation. Determine if the root cause was the result of an acute event or chronic condition. You can have chronic acute respiratory failure, neuromuscular diseases such as muscular dystrophy and Guillain-Barré, irreversible neurological injury, ALS, the amyotrophic lateral sclerosis, MS, which is muscular sclerosis, and central sleep apnea or obstructive sleep apnea. Utilize the root cause to develop the weaning plan from aggressive to gradual approaches. Each patient's weaning plan will be different and should be on a case-by-case basis that allows a member to be successful with a weaning based on the root cause that resulted in the utilization of mechanical ventilation. You want to perform spontaneous breathing trial testing prior to the initiation of weaning. This shows the resident's readiness for weaning and if they have the ability to breathe spontaneously. You want to utilize AVAPs, pressure support ventilation, pressure control, SI and V modes for aggressive or gradual weaning. Keep in mind that many chronic ventilator patients do not tolerate pressure support ventilation and may be successful with utilizing high molecular heated humidification to progressively wean towards liberation. You want to recognize that each resident may have failed traditional ventilator weaning approaches, resulting in the need for prolonged mechanical ventilation. Understand the traditional weaning parameters such as negative inspiratory force, rapid shallow breathing index, and the vital capacity may not be optimal for each resident. Consider other clinical presentation factors prior to the initiation of weaning, such as heart rate, respiratory rate, temperature, hemoglobin, hematocrit, and other factors. You want to evaluate anxiety and pain management prior to the initiation of weaning. The negative inspiratory force is the indication of airway compromise. If NIF drops below 20, respiratory support is indicated. The values -20 and -25 indicates the readiness to initiate weaning. The rapid shallow breathing index helps identify the readiness to wean, as well as assist clinicians to identify patient at risk for failed extubation. The RESB measurement above 105 indicates failure to extubate, and the measurements below 105 indicates readiness to wean successfully. The vital capacity is a measure of the respiratory muscle endurance. You achieve a vital capacity measurement by measuring the max inspiration followed by a max expiration. Patients with anxiety and depression disorders may benefit from medications or psychological therapy to assist with the initiation of the weaning process. Understand the traditional weaning parameters such as negative inspiratory force, rapid shallow breathing index, and vital capacity may not be optimal for each resident. The negative inspiratory force is the indication of airway compromise. If negative inspiratory force drops below 20, the respiratory support is indicated. If the value is -20 to -25, this indicates the readiness to initiate weaning. The Rapid Shallow Breathing Index helps identify the readiness to wean, as well as assist clinicians to identify patients at risk for a failed extubation. The RESB measurements above 105 indicates failure to extubate. Measurements below 105 indicates the readiness to wean successfully. The vital capacity is the measure of respiratory muscle endurance. You achieve a vital capacity measurement by measuring the max inspiration followed by a max expiration. Consider other clinical presentation factors prior to the initiation of weaning, such as heart rate, respiratory rate, temperature, and hemoglobin, hematocrit, and other factors. Evaluate anxiety and pain management prior to the initiation of weaning. Patients with anxiety and depression disorders may benefit from medications or psychological therapy to assist with the initiation of the weaning process. Explore multiple options for the initiation of ventilator weaning. Consider adjusting the mode. Consider adjusting the respiratory rate. Consider adjusting the pressure support. Consider adjusting PEEP, and consider adjusting the FiO2. You want to consider adjusting the mode. You have SIMV pressure control. This is a synchronized intermittent mandatory ventilation that delivers a mandatory set rate with a set volume while also allowing spontaneous breaths. You want to consider AVAPs. You have the average volume assured pressure support. This integrates both volume and pressure controlled ventilation. You have the IPAP range is set to adjust from a breath to breath to meet a target tidal volume. You have your pressure support ventilation. This is the most comfortable mode of weaning for invasive patients and provides supportive care to non-invasive patients. Spontaneous breaths are supported during inspiratory phase by adding pressure to make breathing easier. Adjusting the respiratory rate will improve and maintain adequate carbon dioxide exchange. Consider adjusting the respiratory rate. Adjusting rate will improve and maintain adequate carbon dioxide exchange. Increasing the rate will decrease the CO2, and decreasing the rate will increase the CO2. You want to consider adjusting the pressure support. You want to start with a pressure support of 10 and titrate up or down by 5 depending on the member's respiratory rate. The normal respiratory rate is 12 to 25 breaths per minute with a tidal volume target of 6 to 8. If a respiratory rate is outside the normal range, and if the tidal volume is lower than the ideal body weight, this indicates that more pressure support is needed. You want to consider adjusting the PEEP. The PEEP keeps the airways and the small lung spaces open to allow adequate oxygenation when a patient cannot breathe on their own. You want to consider adjusting the FiO2. You want to wean the FiO2 to 60, then begin weaning to optimal PEEP, which is 5 to 7. You want to consider advanced technologies to promote and maintain the ventilator weaning progress. You want to utilize humidified high-flow therapy or high-velocity nasal insufflation therapy to maximize humidity and to minimize infection opportunities. Utilize humidified high-flow therapy or high-velocity nasal insufflation therapy to maximize humidity and to minimize infection opportunities. High-velocity, high-flow therapy is very beneficial for mechanical ventilation weaning liberation due to providing humidification, improving oxygenation, and providing a set flow to ensure the airway remains patent while spontaneously breathing. The benefits of the high-velocity, high-flow therapy: it improves hypoxemia, improves work of breathing, aids in secretion management with humidification, and improves arterial oxygen pressure and prevents hypercarbia. When weaning on the airvo, begin by weaning the FiO2 first, followed by weaning down the flow. You can reach a max pressure of 60 with humidification degrees reaching 31 degrees, 34 degrees, and 37 degrees. Utilize mechanical in-exsufflation, high-frequency chest wall oscillation, and intrapulmonary percussive ventilation to maximize secretion management and to minimize infection. Utilize mechanical in-exsufflation, high-frequency chest wall oscillation, and intrapulmonary percussive ventilation to maximize secretion management and to minimize infection. You have your cough assist, which is the mechanical in-exsufflation. This is utilized to assist with airway clearance in patients with neuromuscular diseases that cannot produce a strong, productive cough. It improves cough efficiency and airway clearance, allowing weaning success and prevention of infections. It allows clearance of the peripheral fluid in the lower lungs that cannot be expelled through suctioning. This works by creating a positive pressure and increased pulmonary insufflation followed by exsufflation using negative pressure. You have your chest vest, which is the high-frequency chest wall oscillation. This allows drainage of the lungs by percussion and vibration on the chest wall, allowing adequate airway clearance. Commonly utilized in patients with respiratory diseases such as cystic fibrosis, COPD, and frequent pneumonia and infections. Next, you have your IPV, which is the intrapulmonary percussive ventilation. This creates a small, fast burst of air that helps air get around and behind trapped mucus to open the airways. This is typically utilized with residents with cystic fibrosis and COPD in the hospital setting. Assess the resident's progress with ventilator weaning trials to determine if the process should be maintained, accelerated, or slowed. Continue to customize the weaning approach for each resident based on their weaning progress and clinical presentation. Communicate all changes and updates to the weaning approach with the resident and the clinical team. Communication with any changes and updates regarding a resident can determine the course of plan for the member and how we can achieve the best outcome for this resident. Communication with staff has a huge impact on determining the best plan for the patient to be successful with reaching their full potential. You continue to customize the weaning approach for each resident based on their weaning progress and clinical presentation. Every patient will be different with a weaning plan based on their current diagnosis. What may work for one patient may not work for another. By continuing a weaning plan that accommodates a patient's needs, this allows for the patient to wean successfully and possibly prevent further utilization of mechanical ventilation. You want to consider adjusting the tracheostomy tube size, style, be physically present during the initial ventilator weaning trial. You want to reassure the resident by remaining at the bedside for an extended amount of time during the initial trial. Respiratory therapists in other settings often leave the room after the initiation of weaning, resulting in anxiety and often failed trials. The benefits from downsizing the tracheostomy for the weaning purposes: it decreases airway irritation, improves force and quality of cough to clear secretions, improves swallowing, and allows for better speech opportunities, and can allow a patient to use the PMV, which is the speaking valve, better eating and swallowing, and increased duration of capping trials. Downsizing should not be considered until patient is hemodynamically stable, as well as tolerating the deflation of the current tracheostomy cuff. The next topic that we will discuss is tracheostomy liberation and the weaning best practices. You want to understand the underlying cause for the tracheostomy placement. Identify the root cause of the event requiring the initiation of mechanical ventilation, which resulted in the need for prolonged mechanical ventilation. Determine if the root cause was the result of an acute event or a chronic condition. Utilize the root cause to develop the weaning plan from aggressive to gradual approaches. Determine if the root cause was the result of an acute event or chronic condition. Extended utilization of mechanical ventilation with the ET tube in failed weaning attempts and failed extubation, vocal cord paralysis, throat cancer, neurological disorders, anoxic or traumatic brain injuries, or any emergency that obstructs a patient's airway when breathing. In some cases, many patients will have a trach placed and will be discharged home and never assessed for decannulation, but has shown the capability to protect their own airway, swallow without aspiration, and utilize capping or PNV with no complications. Utilize the root cause to develop the weaning plan from aggressive to gradual approaches. Each patient will require a different weaning plan based on their current diagnosis and or root cause that require tracheostomy placement. Every patient will not wean at the same pace. Recognize each resident may have failed previous tracheostomy weaning approaches, resulting in the need of continued tracheostomy placement. Determine if the resident can protect the airway. Determine if the resident has copious secretions. Consider other clinical presentation factors prior to the initiation of weaning, such as heart rate, respiratory rate, temperature, hemoglobin, hematocrit, and other factors. Evaluate anxiety and pain prior to the initiation of weaning. By gathering this information, it can allow you to form a weaning plan that best accommodates the patient's needs to prevent failed liberation from a tracheostomy. Explore multiple options for the initiation of tracheostomy weaning. Consider downsizing the trach tube. Consider attempting speaking valve trials with humidified high-flow therapy or high-velocity nasal insufflation therapy. Consider attempting capped tracheostomy trials with humidified high-flow therapy or high-velocity nasal insufflation therapy. Coordinate tracheostomy weaning trials with speech therapy when applicable. In some cases, speech therapy will initiate PNV following a swallow study to ensure a resident with possible swallow impairment is not at risk for aspiration. You want to consider attempting speaking valve trials with humidified high-flow therapy or high-velocity nasal insufflation therapy. Humidification can allow for proper secretion management and infection prevention. You want to consider attempting capped tracheostomy trials with humidified high-flow therapy or high-velocity nasal insufflation therapy. Humidification and flow can allow the resident's airway to remain patent while managing their secretions. Often, finger occlusion tests can be completed prior to speaking valve or capping trials to assess air movement in the upper airways and ensure that there is not an upper airway obstruction present. Be physically present during the initial tracheostomy weaning trial. Reassure the resident by remaining at the bedside for an extended amount of time during the initial trial. Respiratory therapists in other settings often leave the room after the initiation of weaning, resulting in anxiety and often failed trials. Almost 100% of patients have failed their first weaning attempt due to anxiety. You want to consult psych to initiate assessment and create a plan to better control patients' anxiety to improve overall outcome of the patient's weaning and goals. Consider advanced technologies to promote and maintain tracheostomy weaning progress. Utilize humidified high-flow therapy or high-velocity nasal insufflation therapy to maximize humidity and to minimize infection opportunities. Utilize mechanical in-exsufflation, high-frequency chest wall oscillation, and intrapulmonary percussive ventilation to maximize secretion management and minimize infections. Utilize non-invasive positive pressure ventilation to promote tracheostomy decannulation in certain disease processes such as alveolar hyperventilation syndrome and some neuromuscular diseases. Non-invasive ventilation is a form of mechanical support in which positive pressure delivers a mixture of air and oxygen throughout the lungs via non-invasive interface. Here is a clinical example of non-invasive ventilation utilized during tracheostomy weaning. Patient has a history of morbid obesity, chronic hypoxemic, hypercarbic respiratory failure, and COVID-19. This patient required tracheostomy placement due to respiratory failure with prolonged ventilation and was decannulated but required a second trach due to noncompliance with non-invasive ventilation therapy and went into cardiac arrest. Patient was liberated off the ventilator for the second time and utilized capping trials for 3 months, increasing the duration of trials continuously with nasal cannula utilization. The patient continued to utilize the capping trials continuously and utilized the non-invasive ventilation via the nasal mask to ensure the patient was going to be compliant prior to decannulation. Patient is now decannulated and utilizes non-invasive therapy 10 to 12 hours a day, and the end-tidal CO2 has remained within normal limits, and the patient has not required utilization of O2. By working on capping trials with non-invasive ventilation, this allowed for a successful weaning liberation from a tracheostomy. You want to assess the resident's progress with tracheostomy weaning trials to determine if the process should be maintained, accelerated, or slowed. Continue to customize the weaning approach for each resident based on their weaning progress and clinical presentation. Communicate all changes, updates to the weaning approach with the resident and the clinical team. Next topic that we will be discussing is the weaning assessment tools. Utilize a weaning assessment tool on a monthly basis. You want to evaluate each resident for weaning potential consistently to identify windows of opportunity for weaning initiation. You want to track changes in the resident's weaning tool assessment from a month-to-month basis. Then you want to initiate ventilator and tracheostomy weaning for residents when indicated. Evaluate each resident for weaning potential consistently to identify windows of opportunity for weaning initiation. For mechanical ventilation, you want to attempt modes such as pressure support ventilation, AVAPs, SIMV pressure control to assess the patient's ability to tolerate weaning modes. Is the patient able to clear secretions? Are they able to produce a strong cough? Can they stay alert and awake in an upright position? Is the member breathing over the ventilator spontaneously? You want to track changes in the resident's weaning tool assessment for month-to-month basis. Each facility should have a weaning tool assessment plan that provides a weaning plan for each individual patient. For example, begin weaning on AVAPs for 2 hours and increase by 2 hours until 24 hours is achieved, then proceed to the next weaning step. Initiate ventilator and tracheostomy weaning for residents when indicated. Trach and ventilator weaning, can the patient protect their own airway? Is the O2 above 90% on an FiO2 of 40% or lower? Are they hemodynamically and cardiovascular stable? Can they stay awake more than 15 minutes in an upright position? Keep in mind, many patients may not be a candidate for decannulation, but can be weaned to their max potential. Next topic we will be discussing is monitoring and safety measures. Monitor ventilator and tracheostomy weaning residents with continuous pulse oximeter. Utilize the continuous monitoring to assess weaning success, extend or discontinue. Monitor the ventilator and tracheostomy weaning residents with end-tidal capnography every 4 hours or more frequently. Utilize the continuous monitoring to assess the weaning success, extend or discontinue. Utilize the continuous monitoring to assess weaning success. By utilizing continuous pulse oximetry on weaning patients, this allows to closely monitor the member's SpO2, the respiratory rate, and the heart rate to ensure the member is remaining hemodynamically stable during the weaning trials. If a patient shows instability, changing to weaning may occur to better accommodate the patient's needs based on their diagnosis. You want to utilize the continuous monitoring to assess weaning success. By utilizing end-tidal capnography monitoring, this allows for the patient's carbon dioxide levels to be monitored to ensure the patient's end-tidal CO2 is remaining between the normal limit, which is 35 to 45. Chronic ventilator and weaning ventilator patients' end-tidal CO2 should be checked every 4 hours and 1 hour following any changes made to the patient's weaning settings. The tracheostomy weaning patients should have their end-tidal CO2 checked twice a day or 1 hour following capping trials. Keep in mind that based on a patient's diagnosis, the patient may require more frequent end-tidal CO2 monitoring if high levels of CO2 are present. Use a monitoring system which records and reports all events. Create additional layers of safety through redundant alarm systems with alarm escalation. Create accountability through review of alarm events with accompanying responses. Number one result in missed alarms and increased deaths in emergency situations in a hospital or facility location is alarm fatigue. Alarm fatigue is when clinicians are exposed to excessive amounts of alarms, which can result in desensitization and increased number in missed alarms. Ways to prevent alarm fatigue include increase the visualization of alarms, remote displays, speakers that are audible in each room and hallway, increase the autonomy by creating an order set of alarms for an individual patient's needs. For an example, COPD patients' alarms will vary due to their diagnosis. In some cases, a low SpO2 alarm will be set to 82 to 86 in a COPD patient, where the standard low SpO2 alarm is set at 88%. You want to determine alarms that are critical, such as the low SpO2 alarms, high or low respiratory rate, high and low heart rate, or any kind of arrhythmia. Use a monitoring system which records and reports all events. Create additional layers of safety through redundant alarm systems with alarm escalation. Create accountability through review of alarm events with accompanying responses. Educating caregivers and staff on proper alarm parameters in the hospital facility settings or home settings. Many alarms will go unnoticed or dismissed due to staff members not understanding the meaning behind the alarms and what they stand for. By educating staff on thresholds of understanding values of these alarms can lower the number of missed alarms and critical incidents in facilities. Now we will discuss post-liberation care and monitoring. You want to continue monitoring all recently ventilator-liberated residents with continuous pulse oximetry and end-tidal capnography every 4 hours for a minimum of 7 days. You want to utilize the findings from the pulse oximetry and end-tidal capnography to prevent setbacks and returns to mechanical ventilation. You want to continue monitoring all recently decannulated residents with continuous pulse oximetry and end-tidal capnography every 4 hours for a minimum of 3 days. You want to utilize the findings from the pulse oximetry and the end-tidal capnography to prevent setbacks and return to the tracheostomy. You want to utilize additional therapies to prevent any clinical setbacks. Consider humidified high flow therapy or high velocity nasal insufflation therapy. Consider positive expiratory pressure or positive airway pressure therapies. Consider mechanical in-exsufflation, high frequency chest wall oscillation, and intrapulmonary percussive ventilation. Consider humidified high flow therapy or high velocity nasal insufflation therapy. This can provide breathing support post-decannulation and liberation from mechanical ventilation. This delivers oxygenated air and removes waste gases. This is great for residents suffering from hypoxemia or hypercapnia. You want to consider positive expiratory pressure or positive airway pressure therapies. You have PEP, which is the positive expiratory pressure. These are going to be your flutter valves and the acapella. This helps expand the airway and expel mucus, and it also increases the lung volume. Next, you have your PAP therapy, which is your positive airway pressure, commonly utilized in residents with sleep apnea. You have your CPAP and your bilevel therapies. This applies pressure to the resident's airway, allowing the airway to remain patent during sleep. A sleep study is required to determine if PAP therapy is indicated for a patient. You want to consider mechanical in-exsufflation, high-frequency chest wall oscillation, and intrapulmonary percussive ventilation. This allows for proper airway clearance and secretion management to prevent mucus buildup and infections such as pneumonia. Now it is time for a knowledge check. Question number 1. What does the rapid shallow breathing index determine? The RESB is an indication of airway compromise. This helps assess a patient's readiness to wean. This is the most critical value when weaning someone from an ET tube on mechanical ventilation. Question number 2. What are the benefits of remaining physically present during the initial ventilator and tracheostomy weaning trial? Remaining at a patient's bedside can increase the chances of successful weaning. Question number 3. What are some examples of advanced technologies that can promote or maintain ventilator tracheostomy weaning progress? You have your cough assist, your chest vest, and your intrapulmonary percussive ventilation. All of these are great tools to prevent future infections, pneumonias, and allow adequate airway clearance to clear secretions. Question number 4. What are the benefits of monitoring end-tidal carbon dioxide levels during weaning? Utilizing end-tidal carbon dioxide monitoring allows for staff to ensure a patient's carbon dioxide levels are remaining within normal limits during and/or after weaning liberation. This is the most successful tool that you can use when weaning someone off a ventilator or tracheostomy decannulation. And lastly, question number 5. What are the benefits of downsizing a tracheostomy? The benefits of downsizing a tracheostomy include it decreases airway irritation, improves the force and quality of cough to clear secretions, improves swallowing, and allows for better speech opportunities such as the speaking valve, capping trials, or even eating meals. My name is Caitlin Walker. I'm a respiratory therapist with Eventa, and thank you for listening to my presentation on weaning approaches.